Welcome to AETCM channel. Today we are going to discuss a case of an iron deficiency anemia patient who we presented to the emergency with low hemoglobin. Shall we start?
Yes.
On patient's arrival, patient was able to talk in a full sentence, and he was looking pale in color and is fully conscious and oriented in this. This is the first and second assessment. Then we had connected to the leads and started with the primary survey. Airway wise, the patient was talking in one full sentence. He's having airway patent, no gurgling sounds, no pooling of secretions, and no any stridor or hoarseness of sound. And breathing wise, his saturation was 99% in room air and respiratory rate is 20 per minute. Bilaterally equal raise in the chest and bilaterally air entry equal. Next, circulation wise, the patient was looking pale in color, peripheral pulses were palpable, heart rate was around 99 per minute, and BP was 70/50 on initial measurement, ma'am. And his CRT was.
What is the heart rate?
99.
Okay.
And capillary refill time was 4 seconds, ma'am. So at this point, we put 2 wide bore cannula and 1 pint NS bolus was given, ma'am. After that, disability was GCS E4 V5 M6, ma'am, and bilaterally pupil 2 mm in size and equally reactive, ma'am.
Okay.
And exposure wise, patient was febrile. Hypothermia was prevented by providing blankets, and GRBS was 218, ma'am, 218 mg per dl. After completing the primary assessment, again we assessed because after giving the fluids, we given the fluids as his BP was low. And next, coming to the secondary survey.
What was the BP?
BP was 70/50.
After giving fluids?
After giving fluids, it stabilized at 110/90, ma'am. And we took an adjunct to the primary survey ABG, ma'am. In the ABG, there was no acid-base disorder, but lactate was 3.1, ma'am.
Hemoglobin?
Ma'am, in this hemoglobin was 4.8.
Okay. So, is it justifiable to give fluids in a patient with anemia?
Right, no, initial.
Initial time, if we already know this patient is having anemia, then we should check the IVC status, patient's hydration status, echo, and then only we should give fluid boluses. So, what will happen if we unnecessarily give fluid bolus in a patient with anemia?
There will be dilutional. Dilution of the
again the dilution will happen,
okay. And the patient still feels hypoxic.
Yeah, the thing is, this patient is a young male, no?
Yes,
so, in elderly patients and all, anemia-induced cardiac failure will be there. So, if we again give fluids, then that will be a overload for the heart. Okay, so in this patient, ideal correction should be with
PRBC. Right now, initial assessment wise, we just started with it. And then we got, as we seen the hemoglobin being 4.8, we ordered for the blood. Immediate blood grouping and to be sent for that, and 1 point bolus of PRBC was started.
So before that, what was the hemoglobin before giving PRBC? What all things we should check?
Before giving, we should check for the IVC status, heart.
IVC status, that we are checking for the fluid intravascular volume status. We need to check before giving volumes.
Yes.
Before giving PRBC, what all things we should check?
Cross matching.
Blood group cross match. Anyway, that will take time. No,
yes,
just before secondary assessment, we won't be able to give the PRBC. So we have arranged for PRBC, blood group, and cross matching. What else should we send for this patient? We need to, if we correct the hemoglobin by giving PRBC, we won't be able to know why the hemoglobin came down. So what all will you send?
We should send for all the markers like serum ferritin, TIBC, and LDH, vitamin D, B12.
Okay. So why are we sending all this?
To just to know what is the cause of the anemia which is happening.
Okay. So what all did you send?
Serum ferritin. Serum iron and TIBC and vitamin B12, serum LDH and peripheral smear.
Peripheral blood smear. Okay. And before transfusion, if we are suspecting patient is having anemia, we want to send some more investigation that we will discuss later. Okay, fine.
Okay. So coming to the secondary survey, patient is not having any allergy to any medications, and patient, the previous history is a known case of type 2 diabetes mellitus with hypertension with CAD, status post PTCA, and even he had in the November of 2022, he had a posterior circulation infarct in left medullary region, ma'am, which was completely resolved now. During that infarct time, then they had found that he was iron deficiency anemia, and he was started with iron tablets during that phase. And the events relating to this event, for last 2 months, he stopped consuming the iron tablets, and for the last 5 days, he started feeling some sort of weakness and dizziness. 5 days ago, he had a black color stool episode of 2 episodes of black color stools, passing black color stools, ma'am. And after that, for the last 2 days, he was feeling extremely weak and dizziness, and even not able to perform daily activities like having food and everything. For which outside hemoglobin, he had taken a lab test of hemoglobin and it showed 5, for which he had presented to the ER.
So what is the importance of asking the history in an anemia patient?
To know the cause of
Anemia. So we are taking the past history of the patient. So this patient is having CAD history.
Yes.
So CAD means this patient have a high tendency to go into anemia-induced cardiac failure. And what should be the cutoff of HB?
10.
HB between anywhere between 8 to 10 we need to target. If it is a normal patient,
until 7.
Until 7, less than 7 we need to transfuse blood. So that history is important. Then this patient, he is having CAD, so he might be taking any antiplatelets, like aspirin, cloplet, anything he might be taking. So that itself has a tendency to cause GI bleeding, and bleeding will be there. Okay. Then other drug histories, we need to ask whether patient took any NSAIDs or a patient is on any warfarin or other therapies or anything. And in case of female, what else?
Regarding the menstrual
cycle and how much bleeding came. So this patient had black color stools. Any history of hematemesis?
No.
Any skin bleed or any swellings anywhere?
Of any bleeding sites anywhere?
Sites was not there. Okay. Any what other history we should ask? Other than anemia history, we need to ask history of anemia-induced cardiac failure features. Whether the patient is having exertional dyspnea, or patient might can get a type 2 MI even with this anemia. So we need to ask history of chest pain, exertional dyspnea. These things also should be asked. Okay.
No such history, ma'am, except that he is feeling extremely tired and weakness. No any breathlessness condition. No complaint of any chest discomfort or chest pain as of now.
Okay. Does he have any history of previous malignancies, any hematological malignancies?
No history of any malignancies.
Okay. Then what other things we should ask? Whether this patient anyway, we know he had a past history of iron deficiency. So that might be the cause. We need to ask about the diet also, whether the patient is a vegetarian.
Yes.
That also should be inquired. Okay.
Non-vegetarian diet, ma'am. And then we had sent after the secondary survey, after the blood arrangement, we had transfused the blood, and then we sent for the complete like iron anemia profile, ma'am, like getting the...
No. Before transfusing the blood, we have just sent for blood group cross matching. We asked the secondary survey. Then after in the secondary survey, after sample history, what we should check? Examination. Okay.
On general examination and head-to-toe examination, patient was looking paler, ma'am, and no icterus, no clubbing, no lymphadenopathy, ma'am. And
why should we check for icterus?
To see if it's any hemolytic and
hemolytic anemia, there can be icterus. Okay.
Then regarding the circulatory examination,
lymphadenopathy?
No lymphadenopathy.
Any hematological malignancy, there can be lymphadenopathy. That also should be checked. Edema?
No, at present no bilateral, no pedal edema.
Okay. Why should we check that?
To check if there is any heart failure.
Failure features that. So that much importance is there for the general examination. Okay. Then you enter systemic examination. Okay.
In the systemic examination regarding the circulation part, ma'am, CVS examination, the patient was on inspection wise, the apex heartbeat was normal. There is
first CVS examination, we need to tell about the pulse. Okay.
Pulse was right now it has stabilized to 78 per minute, and pulse was regular normovolumic, ma'am, and all peripheral pulses are present. CRT is 3 to 4 seconds, ma'am, and BP was 110 by 90 mmHg.
Okay. Usually in anemia, what will be the change? there will be a collapsing pulse might be there, and the patient will be having wide pulse pressure. That is because this patient is in a hyperdynamic circulation, so this patient will be having wide pulse pressure. That will be the change in the blood pressure. And in serious rest of the things, cardiovascular examination,
In the rest, on auscultation, normal S1, S2 had no murmurs or any added sounds heard.
Is there any specific murmur that we will hear in anemia? There can be ejection systolic murmur in the pulmonary area in case of, that is called as a hemic murmur. And in case of since this patient, if this patient is having some sort of a cardiac issue, if the cardiac function is impaired because of the anemia, a patient might be having a palpable apex beta apex he will be there, that hyperdynamic circulation changes will be there. And if this patient is having anemia induced cardiac failure features, that also should be checked. Bilateral Krebs should be checked. Those features also should be checked in the cardiovascular system. Okay.
Other rest, all the systems were within normal limits.
GIT?
There is no any abdominal, on palpitation, the abdominal was soft, non-tender, no any palpable hepatomegaly or no palpable splenomegaly, ma'am. And
is he alcoholic?
not alcoholic.
Okay.
Not case of alcoholic.
Okay. Did you do a PR examination?
Not at that point of time.
Okay. Rest of the systems were normal. Okay. So this patient's hemoglobin value was 4.6. Okay. 4.6. What is the MCV, MCH value?
MCV value was 65.3 and MCH was 23.2, hypochromic, hypovolemic.
Hypochromic. So what are the differential diagnosis now?
For hypochromic, hypovolemic, we can consider thalassemia, iron deficiency anemia,
then
sideroblastic anemia.
Then lead poisoning. Suppose if MCV and MCH is high, what will you suspect?
In that cases, we can consider as vitamin B12 deficiency, folic acid deficiency, hypothyroidism.
Then if the patient is having CLD, or if the patient is chronic alcoholic, that itself can cause megaloblastic anemia. Then if it is normochromic normocytic anemia,
hemolytic anemia, G6P.
Okay. Any hemolytic anemias can be there, or anemia of any chronic diseases and chronic renal failure patients. This patient, it will be normocytic normochromic anemia. So we check the hemoglobin, we also check the MCV, MCH values. Okay. So since we already got this value as normal, like low value, hypochromic, this thing. So we are suspecting in terms of either thalassemia or iron deficiency anemia, sideroblastic anemia, this thing. So what next investigation you will have to send?
Next we get for the peripherals.
Peripheral blood smear. Okay, what was the smear report?
Peripheral blood smear report was the RBCs were microcytic hypochromic, ma'am. Target cells were present. Few elliptocytes were present, ma'am.
Okay. So microcytic hypochromic anemia
with targets.
What was the score?
Menzer index was 32.65.
What is the importance of that?
Menzer score is the MCV divided by RBC RBC count, which denotes that if it is less than differentiates with 13, less than 13 would be indicating towards a thalassemia kind of picture, greater than 13 would be an iron deficiency anemia.
So we ruled out thalassemia. So it can be iron deficiency anemia. Okay. So in iron deficiency anemia, to confirm that, what all should we send?
For confirming iron deficiency, serum iron, serum ferritin, TIBC would be sent, ma'am.
Okay. What was the iron value?
Ma'am, serum ferritin was 5.56 being low. TIBC was 383.2 in the normal range itself, ma'am. Serum iron was 13.9, which was low.
So what is a normal iron value? It comes between 58 to 158. That value will be there. So patient's iron value is low. Ferritin will be low in case of iron deficiency anemia. And total iron binding capacity in this patient is normal.
But it should be higher.
It should be higher in case of iron deficiency anemia. And when we check the transferrin saturation, this level also, the level should be higher. Okay. So we confirm iron deficiency anemia. Okay. Suppose we are not getting a conclusion in the initial this thing itself. What else investigation will be sent? Before transfusing blood, what investigation will be sent?
Serum LDH.
LDH. What is the importance of LDH?
For hemolysis to check.
Hemolytic. What's the send for this patient?
Yes, ma'am. Serum LDH was 158, which is in
Normal limit. So LDH will be elevated in case of
Hemolytic anemia.
hemolytic anemia. And thing is, in order to differentiate between hemolytic anemia and non-hemolytic anemia, we need to send a retic count.
Yes,
Okay.
ma'am.
So retic count, if it is high, then that is hemolytic anemia. If it is low, then that means it is because of something else. So suppose we are getting a high retic count, then that means it can be a hemolytic anemia. So what all abnormality, what else can be there in hemolytic anemia? This LDH will be elevated. One thing.
Serum bilirubin values can be elevated.
What bilirubin?
Total conjugated bilirubin would be elevated.
So total bilirubin and direct bilirubin will be elevated. So patient will be having direct hyperbilirubinemia will be there. LDH will be elevated. Then what can be the causes of hemolytic anemia?
Sickle
Tell.
cell next G6PD and
We can broadly classify as intravascular and extravascular. So if it is intravascular, it can be either because of the RBC problem. So RBC has a membrane. So RBC membrane problem, what can it be? Elliptocytosis, then spherocytosis, it can be. Then in the enzyme, there can be some problem. G6PD deficiency, pyruvate kinase deficiency can be there. Or if it is in the if it is in the shape, if it is in the hemoglobin, like hemoglobinopathy,
sickle cell
anemia, yes. Thalassemia can be there. So that is the intravascular causes, the RBC causes. Okay.
Extravascular causes can be warm hemoglobin, IgG, and cold hemoglobin.
It can be autoimmune hemolytic anemia. Autoimmune hemolytic anemia, how will we know it is autoimmune hemolytic anemia or not? We need to do the Coombs test. If Coombs is coming positive, then that means it is something autoimmune. So it can be because of cold or warm autoimmune hemolytic anemia. Okay. Then other causes.
Paroxysmal nocturnal hemorrhage.
Okay.
That also can be there. And other than that, microvascular, intravascular hemorrhage.
Extravascular hemolysis. What else can be the cause? Like some infections. Can you tell some infections?
Parvovirus and
parvovirus that can cause pancytopenia. Okay. What other infections can cause a hemolytic anemia?
Infections.
Malaria.
Malaria.
Whatever.
Toxoplasma, malaria.
Then infectious mononucleus. Whatever infections will cause splenomegaly, those things will cause hemolytic anemia. Okay. Then other toxins or any drugs or snake bite or other conditions like MAHA, TTP, these things can also cause a hemolytic anemia. So that is all about hemolytic anemia, but this patient anyway, the LDH is normal. Okay, so we will leave that part. Okay. We are having a patient with normal LDH with these features. Okay. So we confirmed it as iron deficiency anemia. Okay.
Then we consider to start with the parenteral iron injections, and first the blood transfusion to increase it to 8 to 10 so that the hemodynamic stability will be achieved. Post which other even malignancy markers were sent to rule out if any underlying malignancies were present, and planned for even sigmoidoscopy to find the history of the.
So we are planning to transfuse blood. Hemoglobin is at present 4. So how much blood we should transfuse?
Till to get 8 to 10.
Yeah. Okay. So we should note one thing, that before transfusion we need to take all the samples, including the ICT, DCT, these values. Why? Because if we start transfusion and if we take samples, then because we are transfusing some other patient's blood to this patient, so there will be some sort of hemolysis. So this ICT, DCT, these values will get altered. So before transfusion we need to take all these samples. Whether it is required or not required, we will take the samples, and depending on the investigations we will send all these things. So we will take the samples, then we will start blood transfusion. So this patient's hemoglobin is 4. So how much PRBC should we arrange?
5 to 6 pint PRBC.
Okay, so if you are planning to transfuse 1 pint PRBC, how much hemoglobin will it increase?
0.8 to 1.
0.8 to 1. So this patient, if we are targeting a hemoglobin of 8, we need to transfuse 4. Okay, so that much should be transfused. How should we transfuse that?
through two large bore IV cannula.
If this patient is having cardiac failure features, what else should we do?
We should be providing like
If this patient is in pulmonary edema, like nephrogenic pulmonary edema, we can transfuse PRBC during dialysis, so that patient will not be in volume overload and that renal problem won't be there. If this patient is in cardiac failure, we need to transfuse. Should we give a bolus?
No, we should not be giving bolus. We should be giving over a course of 4 to 5 hours with allowing Lasix infusion to.
Along with Lasix, either as a bolus dose, ideally a bolus dose, we should give Lasix along with PRBC transfusion. So this patient, whether PRBC was bolused or not?
PRBC was bolused, ma'am, but he did not still develop any kind of breathlessness or any pulmonary edema features, ma'am.
Ideally, this patient doesn't require PRBC bolus. Even only thing is this patient had hypotension. We can just control the speed and we can give, because if we are giving it as a bolus, we won't be knowing whether the patient is developing some transfusion reaction or anything. So ideally, we should start as a slow infusion. Then, depending on the patient condition, we can plan on increasing the rate. Okay. So how much PRPC was transfused here?
In the emergency room itself, 1 pint was bolused and 1 pint slow transfusion was given, ma'am. After post transfusion, the hemoglobin increased to 6.4.
Okay. And other things, what are, other than hemoglobin, what else? What correction was done? Iron correction.
Iron injection.
How was it given? Okay, we should give it as a iron sucrose injection. We should be giving. Okay, so what can that cause?
Yeah, local irritation
will be there. Yeah. Okay, so iron sucrose should be corrected. And this patient had a history of GA bleed, so that's why you planned on doing an OGD-scopy or sigmoidoscopy. So suppose we are getting an elderly patient, like a 70-year-old male patient with a non case of anemia, no other comorbidities he had. If this patient is coming to us, we need to correct. We need to do a OGD-scopy and see if this patient, elderly male coming with an anemia, we need to send a stool OB and confirm whether this patient is having a stool occult blood positive. If it is positive, we need to plan on an OGD-scopy. He might be having any GI malignancy. So was OGD done for this patient?
Not yet, ma'am. Still there.
Planning to do. Okay. Thank you.